Good morning, good afternoon, good evening to all of you joining us across the world. Welcome everyone. Thank you very much for joining us today for this webinar on learning from rapid data to inform policy on COVID-19 in Zambia and Rwanda. Today we'll share results from the IPA research for effective COVID-19 responses, RECOVR, from Zambia and Rwanda. We will also share results from the Chronic Poverty Advisory Network on poverty monitoring and in the context of COVID-19 in Zambia. I encourage you all to send any questions you have through the Q&A platform. Enjoy the discussion. Next slide. I'm very excited to introduce our panelists today. We have Mr. Salifu Amadu, our country representative, Innovations for Poverty Action. Mr. Leodoma Fura, Research and Policy Coordinator, Innovations for Poverty Action, Rwanda. We also have Dr. Joseph Simbaya, the Director of the Institute of Economic and Social Research from the University of Zambia. We have Dr. Godfrey Biemba, the Director and Chief Executive Officer from the National Health Research Authority, Zambia. And we also have Dr. Elliot Collins, our Director of Poverty Measurement, Innovations for Poverty Action. I will be your moderator today. My name is Tamara Bilima Mulenga. Next slide. I will just zoom out a bit from the results that we're sharing today to speak about the research that IPA is doing. Sorry, I'm having a bit of some technical issues. I'm not able to see my presentation.
Sorry, no problem, Tamara. We're on the slide just talking about RECOVR.
All right. Okay, it's back on. Sorry for that. We are presenting the research for effective COVID-19 responses, which is a survey that has been conducted in more than 8 countries here in Africa and other areas. We, as IPA, we have created a global hub that centralizes research and policy lessons, particularly to provide rapid responses from COVID-19 to help policymakers develop programs and policies that will reflect the response that people have been having towards COVID-19. We have a portfolio of IPA studies that is generating rigorous evidence of more than 60+ studies. And we're advising several governments on evidence-based approaches, which also intends to provide or strengthen research to research and the quality of remote data collection. Next slide. I will now hand over to our director, Dr. Elliot, to take us through the RECOVR Zambia, particularly on the survey information and the timeline. Thank you.
Thank you, Tamara. So I will be leaving discussion of the results of these surveys to my colleagues, but I wanted to thank you first for all being here. I'm was one of the principal investigators analyzing the results of the RECOVR surveys. In particular, I want to introduce you to the Zambia survey, and later on I'll do the same with the Rwanda survey. The survey spanned 2 rounds. One was in June and the other in November and December of last year. So when we refer in these discussions to round 1 and round 2, you should understand that to mean mid-year and end year of 2020. The survey was a random digit dialing survey, so the effort was not to provide very detailed data using an in-person household survey on a sample we already understood, but instead to get as much as possible a representative snapshot of households in Zambia who could be contacted in accordance with COVID-19 restrictions. And so, we think of this as a nationally representative sample of phone numbers. So this, in this survey in particular, there were 1,300 or almost 1,300 respondents with a very high call response rate, in which about a third of those who we attempted to call actually finished the survey. That number went down significantly in round 2, in part because there was simply a lower response rate, and in part because we were not aiming for the same sample size as before. The average respondent demographics are worth considering here. That the survey was around 43% women, and that remained stable across the 2 rounds. Age and education also remained fairly consistent across rounds, as did household size. So this is to say that there was, along most of the observable characteristics we saw, a good deal of balance in the attrition from round 1 to round 2. That said, it should be understood that a random digit dialing survey does not produce a random sample of citizens or households in the country. So this sample is going to be more urban, better educated, and generally speaking, you might expect that labor force participation, for example, will be higher among this group. That said, we see that a significant portion of these households are living in rural areas. There were a significant number of representatives from every region in the country, and a significant number are living under the poverty line, based on our estimates. I'm happy to discuss any of the details of implementation here. The last thing is that we did adjust. We did not reweight the survey to try to make it more nationally representative, though we did reweight it to account for differential attrition. So, next round. Yeah, so this timeline contains enough information that I will not bore you with all of the details. This is just to give you a mental picture of what happened between these 2 rounds and what was happening during them. So this was the first round was very shortly after the lockdown, and the second round was while schools had reopened and things were, as far as one can describe them as such, getting back to normal somewhat. So we hope that the second round will give us not just a snapshot of of what the immediate implications were for the COVID-19 crisis as it was starting, but give us an idea of what are the effects that we think persist when there are no lockdowns, when schools have been reopened. What should we think are the long-term implications of these lockdown policies and of the pandemic? And so I will turn this over, I think, to Salifu to discuss the overall results, and I will be available in the Q&A section to discuss technical details if necessary, though I think most of those will be left towards the end. Thank you very much.
Right. Thank you, Tamara. Thank you, Elliot. And in terms of the key takeaways for RECOVR Zambia, we start with the vaccine acceptance. Just yesterday and Saturday, the ministerial statements on COVID-19 for Zambia both hinted at an imminent deployment of the COVID-19 vaccine in Zambia. which is great news. But as we prepare to kickstart vaccination in Zambia, the question on everyone's mind, or the question that should be on everyone's mind, borders around vaccine acceptance. We find that 75% of respondents would take the vaccine if available, and 76% would vaccinate their children. We did not find statistically significant differences by economic status, gender, or geography in the likelihood of taking the vaccine. The second takeaway is on employment and income. And on that, between the baseline and the 2 rounds, overall employment did not change significantly, but respondents were more likely to see that their earnings had increased in round 2. And a higher proportion of respondents in round 2 reported selling of assets, skipping required payments on loans, and buying fewer inputs in order to pay for food, health care, or other expenses since the onset of the pandemic. And lastly, poor and non-poor respondents cite various barriers to food access, such as amount and variety of food at similar rates. We'll now zoom into findings specific to sectors such as health, education, food security and financial resilience, and economic activity and employment. So we start with our health and COVID mitigation. Here we looked at respondents' perceived risk of contracting COVID-19. And compared to the first round, more respondents in round 2 say they feel their household is at risk of contracting COVID-19. This increased by 10 percentage points between the 2 rounds. Increased awareness or the easing of government restrictions, etc., might have played a role. But still, a majority of respondents, as 53% in round 2, say they do not feel their household is at risk. And of that group, most of them still maintain that it is so because they follow preventive measures. And from the second graph, the number of respondents who think COVID-19 does not exist, or at least does not exist where they live, increased in round 2. Those are small proportions, but the trend is one that we need to keep an eye on. Next slide. Overall, majority of respondents reported always using a face mask or other nose, mouth covering when going out in public in the last 7 days. And out of those who reported such face mask usage, a majority of them, that's about 64% in round 2, as you can see on the graph, say that they use homemade face masks, and about 39% medical, and 10% say they did not always use a face mask in the last 7 days when they went out in public. And the proportion of respondents reporting usage of homemade face masks decreased by 6 percentage points, while the proportion using medical face masks decreased by 10 percentage points. And just so you know, we classified every non-medical face mask as a homemade face mask. The worrying bit is that the proportion of those not using face masks increased by 5 percentage points. From the graph, you can see the third bar, or the third row, you see 2 sets of bars. You can see that it is a significant decrease in the face mask usage. And a lot of respondents who did not use face masks say that it is not necessary. Next slide. On COVID vaccination, as I mentioned earlier, there's encouraging numbers in terms of reported vaccine acceptance, but there's still some 25–24% that will need convincing. Also, most respondents have some doubts about the safety and efficacy of the COVID vaccine. with less than half of respondents strongly agreeing that the vaccine is safe and effective. And then if you look at the last statistic we have, it shows that doctors and healthcare professionals should be relied on in trying to win the confidence of the people, as we find that 65% of respondents trust doctors and healthcare professionals for vaccine information. On to food security and financial resilience. Across rounds, respondents reported increased prevalence in selling assets, skipping required loan payments, and buying fewer inputs to cover basic household expenses. More than half reported depleting their savings to cover household expenses rounds, as you can see on the graph, the second set of bars. Next. We find that respondents have experienced sharp adverse effects from the economic fallout of COVID-19. Rural and urban respondents report similar rates of most barriers of food access and variety within the last 7 days for various reasons, but most prominently high prices of food, which is at 70%, and drops in income at 65%. Rural respondents are more likely to cite food shortages. Sorry. The rural respondents we had were more likely to cite food shortages as a barrier. And to cope with these, over 40% of adults say they have had to limit portion sizes or reduce the number of meals in the past week. Next slide. In situations such as COVID, emergency funds are sometimes needed to weather the storm. We checked how easy or difficult it would be for respondents to raise such funds. And we find that 1 in 5 respondents indicate that they have no source of income for raising emergency funds of 800 kwacha within 30 days. More than 1 in 5 female respondents indicate that they have no source of income for raising emergency funds of 800 kwacha within the 30 days. And here we find that there are no statistically significant differences between men and women's difficulty in raising that amount. Next slide, we move on to education. And across rounds, there was a 12 percentage points increase in parents' concerns about school-age children. As Elliot mentioned, round 1 happened a few months after school closure. So it makes sense that parents were less concerned then. It seems those were the early days. But initially, that is in round 1, as shown on the graph, most parents were more worried about their children falling behind in their education. Now, after schools reopened, most parents are more worried about the health, safety of their children, which makes a lot of sense. We find that poor and non-poor urban and rural parents have similar rates of concern and types of concerns about their school-age children. Next slide. And approximately 50% of respondents report that primary school children are spending at least 1 hour on education at home since schools were closed, which is positive. And also, we find that 1 in 4 primary students spend more than 2 hours per day on education. And the proportion of primary school children who spend no time on education increased by 21 percentage points across rounds. That's from 1% in round 1 to 22% in round 2. And again, it is possible that right after school closure, children, parents were trying to keep up the learning and hence were less concerned, as we saw in the previous slide. But after months of no school, they might have relaxed And maybe that is what is causing the less time being spent on school during round 2. Next. And compared to girls, boys in primary schools are more likely to spend no time on education, although the difference is not statistically significant. And from the graph on your left, generally, you can see that girls are more likely to spend more time on school. And on your right, on the right-hand side, we also observe that a larger proportion of primary and poor students spend no time on education compared to poor students. Maybe because the non-poor students have access to TV, internet, and others, and maybe that might have contributed to this trend. Next. In this graph, we plot in a descending order in terms of frequency the reasons respondents give for why children in their households did not spend more time on education while schools were closed. In the survey, respondents could only give up to 3 responses for reasons for this particular question. And from the graph, you can see that down there, access to radio was not a frequent reason, but access to television appears to be an issue. So this should be a good information for programming. We can move on to the economic activity and employment. From the graph, at baseline, 60, that is around February, as Elliot explained, 8% of respondents reported that they were employed. But from June, that is round 1, to November, round 2, respondents indicate largely maintaining their employment. But in terms of earnings, majority of respondents experience decreased earnings from 53% in round 1 to 59% in round 2. You can see the 2 sets of bars at the bottom of the graph. There was also a significant proportion of respondents indicating increased earnings from 2% to 13%. Next. And compared to their rural counterparts, urban heads of households were more likely to work more hours the last week compared to a typical week in February 2020. And we did not find statistically significant differences between characteristics such as gender and socioeconomic status. Next slide. And then compared to a typical week in February, women were 19 percentage points more likely than men to indicate no earnings. We also observed that men are more likely to have worked in the past 7 days, while women are more likely to be seeking paid employment within the last 7 days. This sort of explains why women were more likely to indicate no earnings. And there are not statistically significant differences between poor and non-poor respondents, their comparative earning trends in this regard. Thank you very much. That would end it. That would be the end for RECOVR Zambia.
Thank you, Salif, for the wonderful presentation. I encourage the attendees to send in their questions through the question and answer platform. We will now hear from Chronic Poverty Advisory Network and then have remarks on policy implications from Professor Biemba. Over to you, Dr. Kambaya.
Yeah, thank you. Great. Yeah, so our study builds on an existing study, but with a very specific focus on the impact or the already seen effects of COVID-19 on people's livelihood. So in terms of background, of course, we know that the risk of impoverishment and further destitution is high, both from social and economic disruptions as a result of COVID-19. So we sought to complement ongoing surveys, such as the one we just listened to, with some qualitative research findings to highlight people's lived experiences of COVID-19. So my presentation draws on qualitative data that we have from the field, and it builds on a study that the Chronic Poverty Advisory Network in collaboration with Zambia and ourselves did way back in 2019. So we went to 9 provinces, going to a ward in each, and we included in our sample 5 rural wards and 4 urban wards. And in each ward, we did focus group discussions, but also life history interviews. For urban, because we had 4 wards, we covered 10 households per ward. And then for rural, we had 8 households per ward. So we had a very rich data set of over 80 households, over or almost or about 150 interviews in there. So then we followed up on 3 of those districts. So we picked on Kabwe, the ward in Kabwe, then in Chipata for the rural side, and then Lusaka. So we did a total of 28 households. And so these are our findings. And so in terms of the different areas of concern, for the poorest, as well as having potential for impoverishment, we looked at economic factors, social factors, education and health factors. But we also gave a significant attention to food security as well. So in terms of food security, and as was highlighted by the previous presenter, we found out that there were delays in receipt of inputs, farming inputs, and so this resulted in low yields. We also had challenges of cost relating to farm inputs, which have escalated in the recent past, and I think this relates to COVID in the sense that with the existing environment, we have seen our currency losing value in relation to major currencies such as the US dollar. And so that has caused an escalating rise in the cost of almost everything, including the cost of food. In terms of economic factors, so what we find in our study is the loss of income from businesses, including also loss of livelihoods. And as you are aware, we had some partial lockdown. And so that meant micro, small, and medium enterprises had to close down. We had bars, saloons, barber shops shutting down. And so that resulted in loss of income from these business owners, but also loss of livelihoods. We had people actually losing employment because their companies were on lockdown or partial lockdown or closed, and therefore they couldn't sustain the employees. But also, as already mentioned, depreciating currency has, and many other factors have resulted into increased cost of basic food items, loss of remittances, capital depletion as well. We have people who, due the lockdown or partial lockdown, stopped operating and depleted their capital basically, and they couldn't, even when the economic sectors were opened up, they could not return to where they were. We have also seen a support network breakdown, as well as social cohesion. And this is quite real. We had a case in one of our households in the rural side, where this person basically lost her husband, and the funeral could not even be attended by very close neighbors in the village, which is unlike Zambia. We know that there are COVID safety guidelines and people are trying to adhere to that, but yeah, she was deeply affected, but also lack of support. So she felt unsupported, and basically she was thrown into some kind of mental confusion. And so that's breakdown in that kind of social cohesion, as well as support networks, because everyone is feeling this pressure, and so they're unable to support. So that has also resulted in reduced remittances and so forth. In terms of education, we had, of course, initially we had school closures, which had their own implications. We have some dropping out, either losing interest because schools have been closed for some time, but also issues of pregnancies, because children now are just idle, and a number of pregnancies resulting, early marriages, others turning to child labor. And so all these were the seen and observed effects, as well as reported, of COVID-19. There were some attempts to do remote learning or virtual learning, but as we know, this couldn't really work, particularly for rural areas. But even in urban areas, it worked with difficulty due to internet connectivity challenges, but also finances. And so, yeah, and in terms of health, again, access to health services and treatment went down. This was mainly reported as a result of fears that probably going to the health facility, one can end up contracting COVID-19. Of course, there's also a bit of lingering lack of trust in vaccines, so we are yet to see how this will play out as vaccines reach the country and are rolled out. But again, some of this mistrust is just as a result of social media reports and so forth. And it is hoped that the Ministry of Health and others can do more work in terms of sensitizing and ensuring that people have the correct information, so that when the vaccine is finally rolled out, people can access it. Yeah, so you see on the far right of your screen, quotations from rural and urban areas. So the first one is talking about how she stopped gardening because people are simply not buying, and she was making losses. This is a rural respondent. So even in rural areas, because people can't receive remittances, then they can't spend, so their spending power is shrinked. As a result, they cannot support the ongoing businesses within their localities. From the urban area, this lady says, I'm getting poorer every day because the cost of commodities keeps increasing, as already alluded to, because of our depreciating currency. And this is not matched with, of course, an increase in income. So overview, these are basically the areas relating to different factors. But we have seen government, of course, coming in with containment measures, which have been, I think, common around the globe. Restricted trading and vending, but also ensuring that this is done in sanitary conditions. Sanitation and hygiene being emphasized, particularly in public places. You need hand washing basin and soap at your workplace or at your business if you're to have people. Also mandatory masking in public places, and social and physical distancing, no crowding. Even, of course, even though we have seen here that much as this is in force, we still see markets being crowded, churches, but at least there's been that decree. Then also reporting to authorities in terms of any insurgence of symptoms. And in addition to that, there have been attempts to, of course, initially school closures, although now they are open. Some borders restricted travel entry through some borders as one of the measures, as well as the initial close down of businesses. So as a result of all those factors, in terms of sectors that were really affected by these containment measures, yeah, we had micro and small businesses reporting failures to resume operation after easing the lockdown measures or the partial lockdown measures, because during the lockdown, they had to fall on their capital and consumed it. So that was a challenge, but also the increased cost of doing business, reduced volume of customers due to fears of COVID-19. I think more and more people fear to patronize these business places. Even to just go for a haircut, you are scared. And so there has been that effect on businesses, which has resulted in reduced income. In terms of remittances, again, we see that for people, especially the elderly, as well as women or female-headed households, particularly in rural areas that rely on remittances from relatives, from towns, there's been again an effect there because there's reduced income for most of these people who are depended on in the urban areas. And because of that, they are unable to remit as they used to. And in some cases, even no remittances at all. In terms of agriculture, as we talked about in brief, we have, despite the favorable rains, expect low yields because of the increased cost of inputs, as well as delays in the arrival of subsidies, fertilizer, and other imports. When you look at the groups that are at risk of impoverishment, I think 4 of these stand out. So one is the unprotected workers in informal and formal sectors. A number of them reported loss of employment, all at least going for months without being paid, which seemed understandable because these businesses are not making any money because they are closed down. But of course, that translates into challenges at household level in terms of livelihoods. And then children and young people, of course, the main effect or disruption of COVID-19 for this group is what we have discussed briefly, the closure of schools, idleness, and then staying home. As you can see, the quote at the bottom there, this narrative says at some point, children stopped going to school because of COVID-19. So as a result, they were just staying in the village, and some of them became pregnant, while some of the boys started engaging in bad activities. So that was one of the effects of these closures. And of course, government cited this when opening up schools in the second wave amidst fears of an increasing number of cases of the second wave. But yeah, government still opened based on this, which also came out from our respondents. Other people also, because they have movement restrictions, limited capacity to sort of fend for themselves, and so have to rely on remittances, support networks. These two were greatly affected because remittances reduced, but also because there's this social distancing. People don't visit as often. Because sometimes it takes a visit for church members, relatives to see the challenges and support. And so those restricted movements also resulted into restricted remittances and more suffering for the elderly. And a lot of skipping meals was reported by this group for a day or even a number of days. And then, of course, women, due to their, particularly in rural areas, having limited resources and livelihood options, or also among the affected group. For the elderly or the sickly, as you can see the quote on the right, have been sick for a long time. And my sister lost her job and she stopped helping me with my monthly allowance. So that was, this is from urban, and it was even more reported from rural areas. So that's basically the groups at risk. Now, what are the coping strategies? What the different groups or different people doing to cope? Well, they are turning to food rationing and cheaper sources, but mainly in terms of food rationing, there was very frequent reports of reduced quality of meals, quantity, as well as the frequency of meals. And some would even report going for a couple of days. Sometimes shifts, some eat at lunch, others eat at dinner within the family, just to sort of reduce the pressure or the quantity of food being consumed so that it can last for much longer. Then the diversification of livelihoods. So we see even non-farming households turning to gardening and farming. And I think we have seen this even in urban areas like Lusaka. People are going in the surrounding rural areas to venture into farming. Yeah, but also venturing into multiple enterprises, particularly for the middle-aged, because they still have the energy and the capacity to do that. In terms of borrowing and drawing from savings, what we see and what we observe from our study is now people borrowing for subsistence. Usually people, of course, they would borrow for medical bills or school fees. But in the COVID-19 era, or in the last year or so, we have seen more borrowing simply for subsistence, and some of these are under very rough conditions. Again, another coping strategy, particularly for businesses, is to make sure they have COVID-19, they adhere to COVID-19 guidelines by having some washing mechanism, soap, and so forth, which costs them a bit, but it's the only way they can manage to maintain customers coming. Also buying, having face masks, so at least they don't deter people from coming who are scared of COVID-19. And in terms of government support, some are relying on this, particularly the COVID-19 emergency cash transfer, which is about 2,400. And during our field work for this work, we found in Kabwe, for example, some receiving, also in Chipata. So this has been of help. Others also mentioned subsidized fertilizers, which they have always received, and school bursaries for college students as being some of those things that are helping them cope. The last slide, in terms of what we see as future challenges for the poor and the near poor households. Again, here we'll pose questions for discussion. We have seen that livelihoods have not returned to the pre-COVID levels for many of the households that we interviewed. So the question probably that begs an answer is, will these disruptions continue until the vaccination program is fully operational, if at all, or even beyond? So how are the government containment measures as well as the solutions to assisting those that have been adversely affected by COVID-19, particularly the poor households, most of whom are already on cash transfer, the social cash transfer? Is the receipt of the support or the one-off 2,400 kwacha sufficient to pull them through and help them return to their previous pre-COVID livelihoods or sustenance at household level? Well, probably more needs to be done, and I think it's a point for discussion. Also, this disruption to education. Of course, now we have seen schools opening again, but already we have some children who have dropped out, some due to costs, because during this pandemic, children were not going to school, and parents also depleted some of their capital. And so when schools reopened, some parents were unable to pay for these children to go back, and they had to stay. Others due to lack of motivation, pregnancy, child marriages, as mentioned. So how can we prevent a lost generation, so to say? The third aspect or area of concern is the disruption of the social networks for support. We have quite a number of families, particularly poor families, relying on these networks. And so with these social distancing measures that have disrupted normal activities, social cohesion, and to some extent also affected social capital, will these return to pre-COVID strength so that then much as people are receiving some support from government, they also benefit from their social support networks. And finally, in terms of social assistance, this seems to be helping, but then the question is it adequate to push people out of poverty? And I think those are some of the policy implications of this discussion. We know that, of course, distributing financial assistance countrywide requires a lot of support. It requires huge resources, but then the amount trickling to the household, is it sufficient? So is the social protection package sufficient to push people out of poverty and sustain them? So yeah, so we are keen to see the reemerging of social protection in Zambia to that level where people are able to be pushed out of poverty due to this support that is being received, rather than the increasing levels of poverty despite the support that is going on to these households. So this ends my presentation. Thank you. We look forward to the discussion.
Thank you so much, Dr. Simba, for the informative presentation. I'll now turn over to Professor Biemba to share his policy insights on the presentations that have been made.
Thank you so much, Bidima, and thank you very much all those that have made presentations. There's a lot of information that has come up. Elliot made a presentation, just an introduction to the methodology, then Salif dived into the actual results, the health part of it, and Dr. Simbaya has just given us an overview of the socio-economic impact of COVID-19. It will be a mammoth task for me to actually summarize everything here and give policy perspectives. So what I've done is basically to pick a few things more in my area, that is the health component. So I have picked a few issues that I feel that these results have policy relevance. That doesn't mean that the other results have no policy relevance. I've just picked a few of these. So first of all, one of the findings, and I think this is opportune for Zambia specifically, one of the findings was that 75% of the 1,278 respondents said they would take the COVID-19 vaccine if available, and 76% would actually allow their children to be vaccinated. See, this is a very significant finding for us. Like I said, it's an opportune time for us. Zambia has approved COVID-19 vaccination. Of course, when you look at this, it shows that there's low but important level of vaccine hesitancy. You can look at it in terms of vaccine acceptance, so you say 75%. But you can also look at it and say, okay, that means we have 25% vaccine hesitancy. So I would like us to look at both. Okay, so what does that mean? It means that we need to target those who said they would not take the vaccine and may not want their children to be vaccinated, because that now we're focusing on vaccine hesitancy. We need to examine the reasons that are given by that 25% that basically said they may not actually take the vaccine. You know, Zambia has come up with a policy of voluntary vaccination. So we need to work with the Ministry of Health Promotion Department to craft essential strategic messages or health promotion messages using the positive results and also reasons for vaccine hesitancy. I'm speaking from Zambia, but I believe that even our colleagues in Rwanda would be looking at the same. I'm not sure if this percentage actually cuts across our two countries, but if they do, I believe that we should look at it in the same way. Now, the other finding was that 65% of respondents trust doctors and other health personnel for vaccine information. I think, again, this is a very important finding. That means that we as policymakers and of course program officers and everybody that is in health that is concerned with policy and practice of health in the event of COVID-19 rather, or during COVID-19 pandemic, should look at this and say, hey, so what does this mean and how do we actually utilize this information? In my view, we need to incorporate this into a COVID-19 communication strategy that will maximize the use of health personnel for messaging. You will appreciate that these doctors and other health personnel are very, very busy. They are in the front line taking care of patients. They work day and night. They are overstretched. But at the same time, this result is important for us. So we need to definitely find strategic ways of ensuring that we utilize the health personnel to deliver health messages. It is also important to analyze the 35% as we were looking at the vaccine, the 75 versus 25. Here we're talking about 65 trusting, but there's that 35 that may not be trusting, or they have other sources of information. What are those other sources? It's important for us to focus on that and see how we could utilize that information for policy. Now, there are some 2 or 3 very related findings that came from Salif's presentation. One of them is the proportion of respondents reporting usage of face masks, that has actually decreased by 16 percentage points. Those that were using homemade face masks reduced by 16 percentage points. But overall, there was also a 5 percentage point decrease in the usage of face masks. Now, I want you to look at that finding versus the other finding that says, in answer to the question, do people feel at risk of contracting COVID-19? And in round 1, 37% said yes. In round 2, 47% said yes. So there was a 10 percentage point increase in terms of risk perception. But at the same time, you see a paradox here in that despite that risk perception increase, actually, in terms of adherence to COVID-19 preventive measures, there was a reduction, as was evident in the wearing of face masks. So there's a disconnect, in short, that we see here. So what does that mean? I think for me, it means there are other factors that may be influencing adherence to preventive measures other than risk perception. Those factors need to be articulated in order for us to advise policymakers and the program officers on what needs to be done or put in place to improve adherence to public health measures. I must say that here in Zambia, lack of adherence to public health measures is now one of the greatest challenges facing the fight against COVID-19. I believe our colleagues in Rwanda might also be in the same position, and probably in other African countries, or maybe in other countries as well beyond Africa. And I do know that lack of adherence to public health measures is one of the catalysts, if you like, to the spread of COVID-19. Hence, we need to advise on what works best to increase adherence, because we are seeing a disconnect. We are seeing a situation whereby people are saying, hey, there is a problem with COVID-19. There's an increase in risk perception, but at the same time, in terms of action, we are seeing something else. So I feel that that is something that we need to look at carefully. But what do we need to do? What messages should be developed based on risk perception and other issues? Here's my suggestion. And there are many other ways. But my suggestion that we use the tested knowledge translation model, such as COM-B model. Now, there are many other models that are out there. And for me, I come from the National Health Research Authority in Zambia, and knowledge translation is one of our key mandates and our key strategies. And we have a lot of focus on knowledge translation. Now, remember that knowledge translation can occur at the policy level, but we want that change to happen at all levels, because we have not seen change in terms of the risk perception and people are basically changing their behaviors. One of the models of knowledge translation is called COM-B. That capability, C for capability, and O for opportunity, and M for motivation. In other words, what that means is that for people to change behavior, they should be able to do so. They should be given the opportunity to do so, and they should be motivated to do so. Now, so how do we do that? We need to create enablers to change. That's capability. We need to create opportunities for change. That's opportunity. We need to develop motivating factors for change. That's motivation. Of course, time will not allow for me to speak more about this, but just to proceed, I have just an interlude before I continue. One is that there's a reflection as I was looking at the methodology, and this is just a commendation for IPA, that as we look at COVID-19 and research under COVID-19 conditions, I see an innovation that IPA used, that the sampling innovation, the random digit dialing of phone numbers. Of course, there's some bias there because it means only those that are phone numbers are accessible. But to me, I see that as an innovation. Now, as I said, I'm concentrating just on the health part. But I think that even when we look at poverty and the results that Dr. Simbaya has presented, you see a lot of socio-economic impact of COVID-19, negative impact of COVID-19. And I was reflecting and I was saying, look, how do we actually, as policymakers and strategists, technical people, utilize this information? And I just put this as a question. Can we consider a health-related conditional cash transfer tied to adherence to COVID-19 measures? We are aware that there's conditional cash transfers out there and it has worked in education. Can this work in this? And it has also worked in other health measures, conditional cash transfer. Since there's already emergency cash transfer going on here in Zambia, and I believe in other parts of the world, can we tie cash transfer to adherence to COVID-19 measures? I won't tell you how to do that, but I think it's an important question that we can ask. So let me end by the following thoughts that I have as well in terms of how do we move these findings now forward to ensure that they are actually translated into policies. One, I propose a targeted in-country dissemination. I believe that here in Zambia, there has been a lot of dissemination of these results, very interesting results indeed. But we need a targeted in-country dissemination. That means deliberately targeting people that matter and will make a difference in terms of translating these results. Number two, we need to develop policy briefs, targeted policy briefs that are based on key findings and recommend more effective ways of, controlling the pandemic and mitigating the impact of COVID-19. What does that actually mean? It means coming up with the COVID-19 risk communication strategies. It means coming up with the COVID-19 behavior change communication strategies. I would like you to, those that are listening and watching this webinar, to look at the 5 strategies that have been proposed by the National Academies of Sciences, Engineering and Medicine Expert Consultation. This report is available on the web. It was done in July 2020. I liked their 5 strategies for helping with both risk communication strategies as well as behavior change communication in COVID. This is very COVID specific. And they have 5, and I'm just going to list them. One is that they advise that we should make behavior easy to start and easy to repeat. So if you find a behavior, for example, you say you should put on masks, it's easy to start. Is it easy to repeat? Is it easy to sustain? We should make it easy to start and easy to repeat. Number 2, we need to make the behavior easy to repeat. Okay? We need to tie the behavior to an existing habit. We need to alert people to behaviors that conflict with existing habits, but not end there, provide alternative behaviors. And lastly, they propose that we need to provide specific descriptions of desired behaviors. So that is in terms of how, when we do the policy brief, those are some of the things we should consider. But the third suggestion that I have, or stage in terms of process of translation, is do a targeted policy brief dissemination. Number 4, we need to deploy strategic engagement and advocacy with policymakers and key program personnel on these findings. Some people call this policy dialogue. I call it strategic engagement and advocacy, and it's extremely important for us. We have developed policy briefs, we have submitted to policymakers, they have just ended up on the shelves. So we don't end at developing a policy and submitting it to policymakers. We need to deploy strategic engagement and advocacy. But last but not least, we need to support implementation. Again, you can engage strategically the policymakers in terms of these findings, convince them that this is what needs to be done, develop a very nice policy brief, but implementation becomes a problem. So when I say support implementation, I'm not saying you have to provide money. No, provide input technically in terms of what actually needs to be done. So my time is, I think, up. I just want to conclude by saying we need a holistic multi-stakeholder approach for both control and mitigation of COVID-19 impacts in the light of the results that we have seen just now. And I want to commend IPA for this extremely important study that covers basically all the areas or all aspects of the COVID response. Thank you so much.
Thank you so much, Professor Bimba, for those insights. We will now turn over to Rwanda to present the results from the RECOVR. Over to you, Leo.
Thank you very much, Tamara, and thank you, Dr. Bimba. That was, I think, a very insightful and helpful commentary about some of the implications of the work we've seen so far. And I hope that some of the results from our survey in Rwanda will complement the insights that you were providing. So for context, our Rwanda survey was very similar in structure to our Zambia survey. It was done as part of a range of, I believe, 7 different country-specific random digit dialing surveys. The dates of the second round survey were October through November, so it happened right there at the end of October, and the sample size was significantly larger here as well. So you'll find that we have smaller standard errors on our estimates when presenting the results. The same caveats apply regarding the respondent demographics, in that we have collected 2 rounds of data. The attrition was quite low in Rwanda, much lower than in Zambia, and was balanced as far as we can tell. However, the random digit dialing method still is disproportionately focusing on male respondents, on relatively young adults, and relatively well-educated urban adults. Nonetheless, the average age of the respondents was 30, which is not too far off of the average age of adults, as far as we can tell in Rwanda. And there was a significant portion of our sample was below the poverty line. So despite our concerns about bias in the RDD method, we still see a significant portion of people working in agriculture, a significant portion of people living below the poverty line. Those, especially with a larger sample, you can still get an informative group of people in what we might think are these underrepresented areas. On top of that, I would build on what Dr. Biemba was saying, in which he mentioned the innovation around random digit dialing survey. I would say that IPA has an entire methods division, which is focused on understanding, now that we have done a number of random digit dialing surveys in different countries around both East and West Africa, we want to understand whether this is a viable approach moving forward. It's not just that it is COVID-19 compliant. It was also much faster, much cheaper, and in general, as a way of getting an even approximately representative sample of a large population. I think it's a cutting edge method that's extremely well understood in the polling and public opinion literature, but not often properly understood in terms of doing social science research like this. So there's a lot more work and innovation to be done here. So moving forward. Again, this is just, I will not belabor the point, but these are the timelines. So the first round was done after the national lockdown, and when people were just starting to recover from it. Hopefully the second round that we're presenting now was while schools were reopening. It gives us a snapshot of what we think the more persistent impacts of the pandemic have been after the lockdowns have been eased. So moving on. And I will only briefly summarize these takeaways. The vaccine acceptance rate, to Dr. Biemba's point, was higher in Rwanda than I think almost any other country we surveyed in at least in Africa, with 85%, and a very high level of trust in government and medical professionals relative to other places we've worked. We see a 7 percentage point increase in the share of respondents working since round one. But as you'll see, overall, the change in employment rate in terms of the number of people who are working at all changed very little over the course of 2020. And where we saw a lot of movement was in the number of people who had decreased earnings in their work or decreased hours in their work, which the situation looked very dire in mid-year 2020 and has improved significantly, but it still shows evidence of significant economic harm. Finally, between round one and round two, the proportion of respondents who said they needed to deplete their savings to cover basic expenses went down, and 40% of respondents still say that they have had to reduce the number of meals that they eat in the past week, which is we use as a proxy for the extent to which people think that their budget is still tight, which did not change significantly between round one and round two, which is to say that insofar as we saw economic impacts, they have decreased but have persisted since round one. So to go into more detail, I will turn it over to my colleague, Leodmir.
Thank you so much, Elliot. As Tamala introduced me, I'm the research and the policy coordinator, Innovation for Poverty Action, Rwanda office. I will take you through the next part of the presentation. It's divided into 4 main sections as per dimension that you have covered during this survey. The first one will be health and COVID-19 mitigation. The second one will be the food security and financial resilience. Then education, close with economic activity and employment. On mask usage, we found that around 94% of respondents report always using a face mask. For those who do not regularly use a face mask, a 3% indicate it's not necessary. And we have also seen that a poor and non-poor respondents report the same rates of compliance with the mask usage. A slightly larger proportion of male respondents report always using face mask, though the difference is not statistically significant. Next, please. We have also noticed that at the time of interview, 78% of respondents report feeling at risk of contracting COVID-19, a slight increase from round 1. Next, please. Yes, still talking about COVID mitigation, and I think Elliot also mentioned this. By the time we were conducting the survey, a lot of vaccines trials were going on, and we asked participants if a COVID-19 vaccine becomes available in Rwanda, whether they would take it. It was good to see that 85% of respondents indicate that they would take vaccine. The majority of respondents would take vaccine because of self-protection, followed by family protection. We did not find statistically significant differences by gender or geography in the likelihood in the likelihood of taking the vaccine. We also found that almost 10% undecided and 5% explicitly saying would not take the vaccine. And of those 5% of respondents who would not take the vaccine, 21% doesn't think vaccine work very well. We also see that 23% of respondents trust doctors, which is also a good indication, and health professionals for vaccine information, but still that was quite low. Whereas 34% do not trust any person or institution for vaccine information. Next, please. Now, going to food security and financial resilience, sorry. Next, please. With regard to the food security, we asked a lot of questions, but in light of this graph, we asked participants in the past 7 days, how many days did they or have or any other dates in the household had to limit a portion size at mealtime due to inability to purchase enough food. And also in a separate question, we also asked how many days did they have or any other dates in their household had to reduce the number of meals eaten a day due to inability to purchase enough food. We have seen that across rounds, there was a 6% decrease in the share of the respondent that had to limit our portion at meal times. The economic fallout from the pandemic continues to hamper respondents' ability to access sufficient food. So in this survey, we have seen that respondents reported to be unable to buy as much food as they usually do because of high food price. That was around 16% that reported that. And other respondents also reported to have reduced income. That was around 59%. And also around 55% experienced the high food prices, while 40% say they have reduced the number of meals in the past week, as mentioned in the previous slide. In addition to higher share of respondents from urban area. In addition to higher share of respondents from urban areas report reducing portion for adults and children in their household, we have seen that 6% in urban areas. And also we have seen a small share of those who reported receiving government transfer in round one, reports reducing portion for adults, that was 43% against 58%. However, this should be interpreted with caution, since presumably those who received transfers are not the same as those who did not. The question asked was about new transfer in both rounds. We have also seen that poor respondents are 10 to 12% more likely to report that high food prices and reduced income prevent them from buying as much food as they would do. Next, please. With regard to the financial resilience, we asked participants to imagine that they have an emergency and they need to pay 1/20 of gross national income per capita, which is, sorry, for Rwanda, around 35,000. So we asked them what would be their main source of money. And we have seen that 14% of respondents could not come up with 35,000 within 30 days, and that 29% could get it from family, relatives, and friends. Next, please. And trying to break down the previous slide into urban and rural categories on what would be their main source of money in the case of emergency. While urban and rural respondents could access emergency funds at similar rates, urban respondents are more likely to rely on their savings, around 18% against 13% in rural areas, and rural respondents are more likely to sell their asset, 20% against 10% in urban areas. We have also seen that a larger share of poor respondents than non-poor respondents reported selling their asset, seeking money from friends or family, or skipping payments to pay for basic expenses since June 2020. And we see that in light of this, respondents from rural areas are more likely to sell their asset or seek food money from friends, family to cover their basic expenses since June 2020. Now, let me take you through the education results. And as you know, education has been one of the key areas that has been affected by the pandemic. We also asked a lot of questions, but here we report a few. And for this specific slide, we have asked households if before school closed in March, whether any children in the household ate at least one meal per day through a school feeding program. So what we have seen is 55% of poor respondent children received school meals before March 2020 when school closed. But since school closed, 45% of children that were reported to have maintained their level of nutrition. But on the other side, since the school closed, 38% of children of poor respondent have had less healthy diet compared to 30% of non-poor. We have also asked participants when school reopened for in-person learning, if they expect school-aged children will allow. Nearly 100% of children were to be being allowed for in-person classes in November 2020, which was also a good sign. Next, please. We observed that between rounds, parents' concerns of their children falling behind in their education decreased by 11%. And we have also seen that 92% of respondents considered the distance learning that was during March, October to be effective or very effective for their children. And the non-poor respondents are 11% more likely to not be concerned about their children's education than poor respondents. And we have also observed that respondents from urban and rural areas have similar perceptions on the effectiveness of distance learning. I'll try to be quick so that we have some time for Q&A. For now, I'm remaining around with the 2 or 3 slides. With regards again to the education, when we asked the number of hours spent per each child during distance learning, we found that at least 42% of children spend at least 2 hours per day on education. And we have seen that Radio Rwanda for 9% was reported to be the most popular distance learning tool. And more than half of households have access to school books for their children's grade levels to continue remote learning. Then, what about the economic activity and employment? A large share of rural respondents and heads of household report working in the past week. That was around 88% against 82%, with over half of those working at the same or more hours. There was a 7% increase in the share of respondents working in the last week since round 1. And among those working, 48% are working fewer hours and 71% experiencing decreased earnings. Next, please. So again, we asked respondents about the household members above 18 years old, if they ran or did any kind of business, work for someone else for a pay, farming, or other activities to generate income in the past 7 days. So we have seen that a poor respondent and the heads of household are more likely to be self-employed and have worked on a family business or farm in the past 7 days. That was around 56% against 37% in non-poor household. Respondents and heads of household from rural areas are more likely to be self-employed or work for a family business. Again, 62% in rural areas against 42% in urban areas. Good. So in light of our findings, and we drew some policy implications, and I want here to thank Dr. Bianca for his good policy insight. I think he already said, and I will not spend much time on this, but I will highlight a few, at least on education, which he didn't really emphasize on. With the children returning to school, we think educators will be challenged to meet students at their learning level, especially given children varying levels of access to educational resources during school resource closures. And we think this will be critical to access learners quickly and periodically to understand where they are in their education. So given that we likely have suffered learning losses and to place students in their corresponding education levels. But we think that, for example, one simple oral reading assessment enable teachers to understand what their learners can do or cannot do, and to tailor instruction to their level. And here we think fast and simple and cost-effective assessment that are available to educators. Just to mention a few like ASEL, ICANN, or WESO. I will not talk much about the cash transfer. I think cash transfer has shown good results in being one of the area to be considered when dealing with their social protection. But of course, there are some of the questions that should be considered when considering this approach. Thank you so much, and we close from here. I think just to have some minutes for the Q&A, we hand over to Tamara for the Q&A. Thank you so much.
Thank you so much to all our presenters. It's been quite an informative webinar. And thank you so much to our policy insight, Professor Biemba. I think that was quite comprehensive and quite some good information for institutions such as ours to consider in doing research to help our government. If you have any questions, please post them in the Q&A. But for now, I would want to pose a question to Salifu and Dr. Simbaya. One of the results from the RECOVR is the concerns that the parents have had in the children falling behind. And I know, Leo, you also touched about assessments to see where the children's education levels are at. I would like to find out if there's any evidence or any interventions that could be used to stem the learning loss that has occurred, especially in thinking about the impact that education has also on chronic poverty. Salifu and Dr. Simbaya, if you'd like to comment.
Okay, maybe I can go first. In Zambia, I think there has been, or there have been measures that are in place. Of course, the policy that supports girl child or girl children who fall pregnant to go back to school with a pregnancy and continue learning and return after delivery and continue has been of help. But also in the recent past, we have seen a movement, particularly in Eastern Province, where even traditional leaders have been engaged by government, and they are in fact retrieving teenagers from marriages and sending them back to school. That is already working, but probably we need it much as it is inscribed in policy. We need more enforcement in terms of that policy to ensure that we mitigate this impact, because the effect has already been, it has already happened, and so we need to mitigate it. Get those who have been affected in such a way back to school while preventing other children from falling into that. In terms of financial support, of course, the bursaries are helping, but then many limited to college students. So parents with students in college talked and thanked government for the bursaries that make it a little easier for them then to turn support to those in primary school, but probably more support in that area will be needed to ensure that families or households are able to stand on their feet and somehow continue sending their children to school and paying for them in a sustained way, because they had this shock, and so they will need some kind of push for them to get out of that shock. Thank you.
All right, thank you, Tamara. Just to add a little bit to what Dr. Simbaya has said, I think there's need to rethink our strategies towards response to emergencies such as COVID. One thing we learned at IP is to move very quickly to random digit dialing approach to sort of mitigate some of the issues around in-person interviews that we could not handle, right? So I think we should again try to maybe look around some sort of remote learning. If there are programs, there are apps, software that we can use to teach even children in school how to use them, so that if there's anything of this sort repeating, or even just normal, just in our normal day-to-day lives, if there are students who would be able to do better through remote learning, then we hook them onto such platforms. It will be good to start thinking about that and not be overly reliant on in-person activities. Our universities, our primary school children, our mothers should be able to get insights into some of these remote learning opportunities. I saw a couple of universities switch to Zoom lessons, and a lot of students struggled ahead to keep up. So some of the lecturers were not very enthused about the whole idea of going Zoom or going remote teaching. We could also do same for our primary school children, maybe teachers just calling. It can be government teachers, it can be like another organization responsible for that. And what they do is just provide remote learning for children and mothers. It might just be just a phone call away, call students, talk to them, send maybe exercises through SMS to such children. They practice, there's a call or a video or whatever, and then these children can be taken through the lessons. I think we need to already start thinking about these and not wait for another pandemic or something similar to happen before we run around again. Thank you.
Thank you, Salim. Thank you. Professor Biemba, you talked about targeted dissemination in country. And I know for Zambia, you've been leading the monthly COVID-19 dissemination for researchers such as ourselves to present findings on COVID-19. And in thinking about the preparation that Zambia is making to roll out the vaccine and the misinformation that you talked about, developing appropriate messaging, how can we be of greater help to government as researchers? How can we partner in amplifying our advocacy and communication? And from the government perspective, what are your plans around that, and how can institutions such as ours and CPAN help in providing the evidence that government needs in such programs?
Thank you so much, Tamara. That's a very important question. Targeted dissemination, how do we do that, and who do we target? My advice that we use existing structures, and in Zambia, we have existing government structures. Technical working groups are very effective fora, because these technical working groups usually are multi-stakeholder groups. So disseminating at specific technical working groups that deal with specific areas. In this case, COVID-19 has a structure. So we have a lot of different groups that deal with COVID-19 response, and targeting each of those groups, disseminating results like this specifically to each of those groups will be very important. In terms of policy decisions at the Ministry of Health, there's the senior management. It is chaired by the permanent secretary. Such a forum will be extremely important because all the directors are available then. But if we had disseminated at the various technical groups, the groups that deal with various aspects of COVID-19 response, dissemination at the Zambia National Public Health Institute, which basically is the main coordinating body for COVID-19 response, then dissemination at the senior management level will be extremely important. But I did indicate that in my conclusion that a multi-stakeholder response is extremely important. That means that you could even lobby further and ensure that other people that are not within the ministry proper, but are part of the health sector, are also aware of these findings. Means that we have to target, we can target even at a higher level. There is a cabinet committee of ministers that deal with COVID-19, and at that level, the vice president chairs. You could even go as far as that. If you are, as I said, when you are doing, you want to make sure that results are translated, you need to be very strategic. That means you must target at each level, and the higher you go, the better, even in terms of making sure that things are done. You can even go and target even the MPs, members of parliament, make sure they know what these results are. So targeted dissemination extremely important. Thank you.
Thank you so much, Professor Biemba. We have come to the end of the webinar. I hope you enjoyed the discussion and you were able to follow through. We still encourage you to send your questions if you have any afterwards. But if you are also looking for information on COVID-19, on our website, we have a RECOVR Research Hub, which contains results from the various countries that IPA is operating in. You can also download the data for the RECOVR Zambia for round 1 and rounds 2 on the Harvard database. Would also want to partner with you. As a researcher, you can connect with us. We do connect researchers with partners, assist with research design, implement data collection, and much more as IPA. As a practitioner, we can also help answer your questions and support you in using evidence to make your programs or policies as effective as possible. In Zambia, we're working with a number of ministries, including the Ministry of Health, and we're also working with various government offices in the countries that we are present. As a funder, our funders also make it possible for us to generate this evidence and inform debates about how to effectively reduce poverty. So if you do want to get in touch with us, you can send us an email on contact@povertyaction.org, and we'll be happy to partner with you. The other details are on the screen. You can also find us on Facebook and LinkedIn, and you can also visit our website for more information on other works that IPA does, including the RECOVR. Thank you so much for joining us, and we hope to see you next time.
Thank you. Bye-bye.